risks and benefits to anything. For instance, there's the potential confirmation of a diagnosis, which is sometimes wonderful. You can initiate a treatment plan if there's one possible. It can potentially be life or vision saving if it's something that is treatable. Unfortunately, a lot of times, especially for inherited retinal diseases, these things aren't as treatable at the moment. Other types of conditions that are inherited can be treated. People who have the BRCA gene for breast cancer oftentimes can sort of mitigate that issue with a mastectomy. In vision, it's a lot more difficult, unfortunately. There's the cost of testing, there's oftentimes testing error. Um, do you want to know if you're going to go blind? It's a lot of big questions. It's each individual has to take that ownership, or family has to take that ownership when considering doing genetic testing. All we can do is sort of recommend these types of treatments. So, what do we as vision care providers do? We have to be aware and sensitive to the fact that these types of conditions even exist. We have to find those clinical findings as low vision teachers, low vision educators. Oftentimes, you guys are seeing things sort of on the latter end. But if you know family members or you're seeing, oh, their brother's coming in and they're starting to show similar signs or symptoms, you can start initiating that process by encouraging the family to get evaluated from a more clinical perspective. And so you want to make the most detailed clinical diagnosis from my end so that we can request the correct test. Making sure that we, of course, educate and have the patient set up with a genetic counselor of some kind. I am not a genetic counselor. I can only tell the patient if they do or do not have a particular gene based on the results given to me. However, other individuals are much better equipped for that to give a patient a better understanding of what quality of life might look like after, and what that might mean for themselves or for their families. And then, of course, making sure they get a written copy of it for their own records, and then providing resources to help assist the patient in achieving or receiving additional care. So what do we even bother testing for in these cases? So you've probably all know these conditions: retinitis pigmentosa, Stargardt's, Leber's hereditary optic neuropathy, or Leber's congenital amaurosis. If you have an infant, oftentimes like infantile glaucoma or early onset glaucoma, these are the multiple different genes that can be present. Um, and then other inherited optic neuropathies like the optineurin gene that are present. So this is not, of course, an exhaustive list, but these are some things to maybe think about if you start seeing potential signs or symptoms within a patient. So there are a couple different, there's a lot of different kinds of genetic testing going on now. But how do we even process that information? What does that even mean for us? How do we use that from a national perspective? And so the Genetic Testing Registry is an organization that, or a system that's collaborating between the National Center for Biotechnology Information and the NIH, and they are putting together this list of individuals who have these genetic results. And so it is meant to be a central location for all of these patients who have these particular genes. Only eye care professionals can submit these results, so that they want to make sure that they're valid results. And it's basically creating this database of individuals who have these particular genes. So if a therapy comes down the pipeline, they're able to access that information, one, for trial patients, but also for potential treatment for them if things go well. And so this it's all voluntary. Only individuals who wish to be submitted into this registry end up doing so, and you can do it all online now. And it's meant to provide potential patients or subjects for treatment trials, especially for very difficult conditions that cause significant progressive vision loss. Um, and so we want to make sure we can reach out to those patients as needed. So there's a couple companies that have kind of crept out of the whole mess of many genetic tests that are out there. Um, there's a huge slew of genetic tests you see nowadays, like My23. They have like your ancestry.com is doing stuff, all these things, but we're talking specifically about inherited retinal diseases. I mean, I think they even have some for like genetic tests for dogs. Who knew? So the My Retina Tracker program is provided by the Foundation Fighting Blindness. So in fall of 2019, in partnership with Blueprint Genetics and Informed DNA, they launched an open access, no-cost genetic testing program called the My Retina Tracker program. So they provide a free genetic testing service for diagnosing inherited retinal diseases. Um, and they're able to use that information for clinical trials as well. However, you can do the genetic test and then say, no, you don't want to be a part of any potential clinical trials. You keep your information safe, but it's a way of fostering potential patient base for these different studies, but also trying to get patients into those studies earlier for potential treatment and improvement in vision. Um, yeah. So this is the list that they currently have. It is a spit test. So you can do it in office. We have a couple of these. We have a couple of our the other tests that I'll get into next. So these are this is their exhaustive list currently, although it's changing pretty continually. And so you've got pretty much everything from achromatopsia to multiple types of ushers, which is a really great list of potential genes to test for, um, and to potentially be able to help an individual. However, it doesn't list all of the exact specific genes that are used. So RP, of course, can be caused by many genes. Choroideremia is the same. There are multiple genes that cause these types of conditions. And so just listing the potential diagnoses doesn't necessarily mean you have a perfect diagnosis of the exact gene. They try to parse it out, of course, much more specifically, but they don't list it on their website or anything. your IRD is by Invitae. It's an inherited retinal disease testing initiative that they started a couple of years ago in order to treat. They have done this initial genetic testing for RPE65, which I'll go into in a little bit, but have since expanded their genetic testing repertoire to include all of these types of conditions, which is a little bit more than the Foundation Fighting Blindness list. Initially, it was free, and then the FDA approved it, so then it wasn't free. It's free again, so which is great, and it has a little bit more of a longer gene list to test from, which is great. And so when you submit it, you can submit everything online now. It's just a spit test done in office. We turn it into the ID or IRD, and they send back results. And they also offer genetic counseling with their system. So does the Foundation Fighting Blindness. They provide counseling options for patients depending upon the condition and depending upon what genes are present and what that could mean for the patient. So one of the biggest things that have come out with these different IRD testing, the inherited retinal disease testing, is the RPE65 gene. You've probably all, or maybe all, heard of this gene or heard of Luxturna. They have sort of monopolized the IRD treatment game with this revolutionary treatment. It's the first treatment to have success in this type of gene therapy. And so what it does is it treats this particular RPE65 protein gene. So your retinal system has a different process that it goes through. You have this layer of retinal cells in the back, the RPE, called the retinal pigment epithelium, and it's a layer that supports and provides nourishment for the retina. In this layer, there's a visual cycle that occurs. So light comes into your eye, it hits the photosensitive pigment in the retina within the RPE. Different cells are changed. So you have this sort of vitamin A type of cell that's transformed. So it's a little bit of a different type of vitamin A. That conversion triggers a chemical reaction that creates electrical signals in the brain. And then the RPE65 gene specifically converts that little changed vitamin A form back to the original form it was in so that it can begin the cycle again. So basically, the RPE65 protein is that reset for the visual system so that you can continue to have it. If it was only once and done, you'd see one stimulus and then you wouldn't see a stimulus ever again. And so this allows that system to continually run so that you continually see stimuli and then reset your system all the time. What happens with the faulty RPE65 gene is when you have mutations in this specific gene, you end up not making that RPE65 protein. This is seen in like LCA, so Leber's congenital amaurosis, and RP. You get loss of function of those cells, or death even of those specific cells, and then eventual degeneration of the photoreceptors surrounding it because they're just not being used. So if you don't use it, you lose it. So what happens is this degeneration of the photocells leads to vision loss, and you see this type of these changes, these symptoms that patients end up having. So they have night blindness, they have a really long time adapting to different light sensitivities. So if you go from outside to inside, inside to out, it takes a very long time for the visual system to adapt to that new light setting. Peripheral vision loss, so you end up with this tunnel vision. And then when we test some things, an ERG is testing the electrical response of the retina, and that becomes significantly reduced over time. As it progresses, you end up with mild to even severe visual acuity loss, so the number that they can see, on the chart. They end up with nystagmus, which is that slight beating of the eyes, and then sensitivity to light becomes very difficult, especially on really bright days outside. So what Luxturna does is it is an FDA-approved RPE gene delivery. So it's a gene therapy that goes in and it's injected right within the retina, so really, really close to that RPE that we had talked about, that retinal pigment epithelium layer where all of that process is occurring. It is a subretinal injection. The gene therapy is injected within that part of the retina to try and compensate for the RPE65 mutation. So it's trying to compensate for those cells that are lost, that aren't producing that protein that isn't resetting the system. It's not recommended for patients younger than 12 months of age. So they've done this in children, but not, they don't recommend it for infants at this time. So to kind of go through the system, the RPE production occurs by the treatment occurs by going in and actually altering the DNA of the cells, the retinal cells, so that they can then produce this protein to get it to express again. Because if there's a failure in the gene, it's not producing that protein. So genes produce proteins that have an action in the body. And these genes, if they're not working, they don't produce that protein and the action isn't made. And so with a functioning RPE65 gene, you produce this normal protein, it's expressed, the visual cycle can begin again. So here's that visual cycle sort of drawn out. You've got that one type of vitamin A, the all trans retinol, then it's changed to all trans retinol. Very slight difference, there's an L to an all. to an all-trans retinol ester. So that's the changing of the shape basically of vitamin A so that it can be used to send a chemical and electrical signal to the brain. And then RPE65 protein comes in and it resets that. So it goes from all to al, the OL to the AL, so that the signal can begin again. The gene therapy goes in and it changes that specific gene that's missing so that it can produce that. Unfortunately, with any type of treatment, there are always adverse effects. Any injection, you can have endophthalmitis, which is an inflammation within the eye itself. You can have potential vision loss. You can have retinal abnormalities, retinal holes, tears, loss of central vision, a retinal hemorrhage, increased eye pressure because you're injecting something into the eye, meaning there's more in there, so it could have higher pressure. You also have to worry about the air bubbles that are injected because if you change elevation drastically, those air bubbles can cause significantly adverse side effects within the eye. So if you travel, if you have a can of soda and you go from a mountain area to a flat area, it kind of shrinks. It's the same situation within your eye that those air bubbles can drastically change size and potentially cause damage to the retina. So if you end up doing this treatment, don't go anywhere. Just stay in the same level of elevation for a while. Because you are injecting something, you can always increase your risk for additional cataract, as well as redness, irritation, pain, and even thinning of the front surface of the eye. So that was RPE65. Luxturna is the only FDA approved treatment option so far for this type of inherited retinal disease, which is a really exciting thing to see. And I think it's a great step for initial gene therapies. There are other gene therapies that have sort of come out the pipeline. However, they're not really FDA approved for widespread treatment. Yet they're just still studies. So Leber's hereditary optic neuropathy is another one that's sort of come out within the past few years. Leber's hereditary optic neuropathy, which is different than Leber's congenital amaurosis. Leber's congenital amaurosis happens much earlier in life. It affects different parts of the retina. Leber's hereditary optic neuropathy, on the other hand, usually affects individuals before the age of 40, usually in young adults, so it doesn't happen usually at childhood. It happens a little bit later on. It is a mitochondrial disease, meaning if you guys remember back to biology really long ago when we were much younger, we always heard of the mitochondria as being the powerhouse of the cell. So within each of our cells in our body, the mitochondria provides that energy source. And so this is a faulty gene within the mitochondria that causes a bilateral, painless, pretty acute, subacute, so it's fairly quick, and progressive impairment and sort of resultant degeneration of the retinal ganglion cells, which are sort of these cells within the retina. As you can see here, the red is meaning loss or thinning in the retina. And so these retinal ganglion cells are lost over time and you can't process vision because these cells are actually dying. So in most cases, these symptoms begin in one eye, and then really shortly after, a couple weeks later, you start to have those symptoms in the other eye. Initially, when it happens, you see this drastic inflammation of the optic nerve. When we look inside the eyes, patients note my vision is suddenly changing. I feel like I'm losing my vision. Things are kind of graying. Everything is going dark. These are types of symptoms that people will complain of. They don't actually have pain usually. They don't end up having, flashes of light really. It's usually just a very slow degeneration of the nerve. That just usually, if you have changes within the nerve, it occurs a very, very extra slow. This one's actually a little bit faster in that sense. So this happens in young adults, usually before the age of 40. It is mitochondrial, and so mitochondria are actually passed from within the female gene. It's technically Y-linked, if you want to call it. So it's going to affect males more frequently than females. However, the mom passes it. And so it results in this optic atrophy and then permanently reduced visual acuity. So men are 4 to 5 times more likely than females to lose vision and be affected in this way. So the inheritance pattern, if you kind of go through, so like I said, mitochondrial DNA can only be inherited maternally, so from the mother, because mitochondria derive from the egg, not the sperm. And all of the offspring of a mother with the specific gene will have that mutation. A male who has it can't pass it on to his children, but it's more common in men in general because they're getting it all from their mother. And so this specific gene is by far the most common gene that's present with Leber's optic neuropathy. Oh, went back. Sorry. And so as you can see, the affected mother, everyone gets it. Affected father, no one gets it. But if you are a carrier, it doesn't necessarily mean that you're going to have as severe symptoms, as was mentioned before. So what are the different types of treatment options? There are potential nutritional supplements. There have been some studies into this to reduce free radicals within the retina to help to reduce progression. So free radicals are not good. They're little O2s. We always hear about them within the environment. You don't want, free radicals. You want to detoxify. That's what it's actually talking about, is getting rid of free radicals, which are it's a O oxygen molecule just floating around that isn't bound to anything. And when that happens, things can oxidize and it's not good for the body. You need it in some instances, but not when it's just sitting by itself. However, not great results in improving things yet. There are activators of mitochondrial biogenesis. So if the mitochondria isn't working, such as in this condition, they try to get that mechanism to work better. So to get that mitochondria, that powerhouse of the cell, working better. There are some suggestions that brimonidine, which is an eye drop used oftentimes for glaucoma, is neuroprotective. And so it could potentially help prevent the nerve in the eye from changing. However, again, all of these are pretty much questionable at the moment. There's no FDA approved, treatment yet. There's the symptomatic and supportive treatment. So that's where we come in as low vision educators, caretakers, all of that. We try to help the individual who has lost vision to live their best life despite their vision loss, with different magnification options, orientation, mobility changes, all of that. Go back. There we go. The newest one that's come out of the pipeline is, I can't even pronounce it, idebenone. The mechanism of action of this is it has antioxidant properties and the ability to act on the mitochondrial carrier, sort of overcoming the mitochondrial complex, and basically fixing the chain of the gene to protein, just like with the treatment of RPE65. It's changing the gene so that the protein is expressed, so that the mitochondria work more effectively. However, the studies that have been done, there's a couple around the nation. I've had a couple patients personally who have had Leber's optic neuropathy, and we sent them for the treatment trial and they didn't qualify. So they have pretty strict requirements for this treatment trial at the current time being. likely COVID has made things even worse. So it's really difficult to get patients in for this treatment trial. But potentially there could be improvement. There was potential of 9 patients in one study, 6 of them improved maybe a couple letters better. Not a great improvement, obviously. However, it is good potential. These are the other genetic therapies currently being tested. So we could see any number of these conditions having some type of potential treatment options coming down the line. And so they also have the specific genes listed, the ones that they're actually testing or treating for currently, which is great to see. Hopefully within the next 10 years or so, we can see a lot more potential gene therapies that we can offer for our patients. There are other studies that are going on by using stem cells to help correct. Oh, is there a question? Okay. There are some stem cells that could potentially correct the retinal tissue that has been damaged. So these little retinal patches oftentimes are implanted within the photoreceptor and retinal pigment epithelium layer. They want to use these types of treatments for AMD and Stargardt's disease, where especially the central vision is changed or altered and there's scar tissue. They're trying to do clinical trials with this, of course. Unfortunately, there are not a lot of success rates with this. Usually they don't take patients until they have a very severe level of vision loss. And the data is definitely still out on the potential benefit, unfortunately. I think there's a lot of really interesting research out there with stem cells, but there's nothing as of yet to suggest a solid treatment option yet with these sort of little patches that they inject. So there are some other studies that are going on where they use stem cells that are induced to act like retinal cells by taking the patient's own blood, developing these little new cells, and then injecting them within the retina to try and treat geographic atrophy for AMD, for Stargardt's, for any sort of central vision loss. It's by using the patient's own stem cells to help produce those retinal pigment epithelium cells to help start that system again, that visual cycle again. However, again, these treatment options, they're all over the country. They're all over the world. They have all these potentially good benefits. You have to have sometimes multiple injections, and yet the FDA hasn't approved anything. There isn't a great success rate. Oftentimes, the benefit is not doesn't outweigh the the benefit doesn't outweigh the the cost, everything that you have to do in order to get these injections. You can increase your risk for tumors within the eye because these brand new little stem cells can just keep growing. There's again all of those potential risk factors that occur when you inject anything in the eye. So that eye inflammation, potential vision loss, even more than what you've already lost. Inflammation, pain, redness, pressure increase in the eyes, all of those types of things can occur. And so as much as they tout being very potentially good, I can't in good confidence recommend them yet, unfortunately. I wish I could. But if you know anyone that ends up having these treatments and they have major success, please let me know. I would love to hear it because I want to be able to help my patients as best as possible. So don't be fooled by their crazy cost and potential improvement that they tout. I think I'd like to wait until the clinical data is present to support it. Okay.
So Emily, before you go to the next session, there was a couple questions that you may want to answer.
Yeah.
One was, The databases, can only ophthalmologists submit, or do optometrists have access as well?
Optometrists do have access to the genetic testing registry, that registry, yes.
Okay, and then the last two, how is
Um,
the IBID?
yeah, so that one is injected as well. Um, it's an injectable. It's like the anti-VEGF or like the RPE 65. So those are injectables. Um, and then current treatments for an indie for macular degeneration. That's a really good question. So they're always doing some studies with macular degeneration. There's um, whether or not injections are actually beneficial for patients who have severe wet macular degeneration. You get to a certain point where it's not as beneficial in those cases. And so there's some question as to whether or not that is as advantageous as we always recommend sending patients for um, uh, injections. However, I would say it's better safe than sorry in those cases because the benefit outweighs the risk in those situations. As for specific clinical treatment trials, um, there are probably some. I unfortunately don't know enough, but I can do some research. If you get my email from this, email me and I will try and look up some additional things and get back to you. That's okay. So I don't know the answer exactly. Any other questions from this section? Okay, great. So I'm going to go on to some of that adaptive technology and devices that I was talking about. Um, so we have a patient, they've already lost some type of vision. Now, how do we help them? If we can't set them up with a treatment trial, how do we improve their activities of daily living? And so, as of late, we've had a lot of new fancy technology, all these headborne devices that everyone's all about, the VR or virtual reality or augmented reality or artificial intelligence that have come out the pipeline that everyone's obsessed with. Um, and so, I'll kind of go over a handful of them and to see what kind of things are available for us. So I'm going to kind of go skip over one that is highly touted, new eyes, simply because I feel that these other options have more to offer than just increased magnification. I think that the assistive technology that's included with these other devices outweighs the potential benefit and cost of the new eye system, even though they've significantly reduced the price finally, which is great. So the IRISVISION, it's a headborne electronic magnifier, as you can see here. It provides 70 degrees of visual field. It has optical character recognition technology. You can use Google Assistant voice activated commands. You can stream video within it. So it basically is this headset with a phone strapped to the front of it. But the phone is connected to Bluetooth, you can connect it to Wi-Fi, all of these fun things to be able to uh, increase increase the magnification of what you're looking at. This one was developed with like eye care providers in mind, and it's actually been fairly successful. Um, we've had a good bit of success with this one. The Patriot Viewpoint is a fairly similar type of device. Again, it has that, as you can see in the little picture, the strapped phone to the headset to increase magnification. It provides multiple contrast levels. It has the OCR technology as well. And it uses just a Samsung Galaxy phone, basically, to do the tasks that you want, which is helpful in knowing that you can use more. I guess it's not simple, it's a smartphone, but regular technology to be able to do and run the program. Google Cardboard uses a smartphone in the same kind of context, except you can buy this for $10 to $40, depending on the level of fanciness you want to get in your cardboard. It uses your smartphone, and you can watch YouTube videos, stream content, look at photos. You do have to come up with your own strap. That's the downside. Or you can buy one, I think, online as well. But it uses the current stuff that you already have for assistive technology and kind of adapts it so you can use it as like a magnification option for near. The IRA is a video-equipped smart glasses device that basically is a camera within the glasses that connects to a trained professional, an agent, that gets you connected to another individual to tell you what's going on in your world. And so you wear your glasses, you tap your glasses, and you are connected with an agent to tell you, what am I seeing? What am I looking at? Where am I? What color is this? And that trained professional will provide that service to you. Of course, you have to be aware that you're paying for a trained professional. So the cost is dependent upon how often you use the service. You have different data plans that are available. And then you're limited by the number of minutes that you use. So that just changes the cost, and it's per month that you pay. So not just for the device or the smartphone link, but you're also paying for that trained professional, which is helpful because they know what to expect when you're using those devices. Oh, free 5 minutes every 24 hours. That's great to know. Okay. And then the other option is Be My Eyes. It is a phone application, so for a smartphone, and it utilizes volunteers instead of a trained professional, but it's free. So that's a bonus. You use your smartphone to connect to someone around the world who has sight and provides that information to you instead. You point your camera what you want to look at, turn on your flashlight when you need to. It has multiple languages, 180. It uses 150 countries, and it connects with people who are awake. So if you are an insomniac like myself, you end up waking up randomly at 2 in the morning, and you need your an assistant to help you. So you use your Be My Eyes app, and you end up with someone in, I don't know, wherever is, I guess, Japan or somewhere, or China, where someone speaks English and can help you there. So there are a lot of great options with this. Unfortunately, though, it is volunteer based. And so sometimes the people that end up helping you can't really help you as well as you want them to, depending on their level of expertise and what you're looking at. But it's a great service. I think it's a great service to have that sort of connectability within the world. Makes it feel a little bit smaller, especially with COVID and the lack of interaction that you have with people. So it's kind of cool in that respect. But it does have a tendency to suck your battery life on your phone. The OrCam is, you've probably heard of this as of now. The OrCam provides, there's a couple statements about the Be My Eyes. Ron says, yeah, so you end up with he says the don't see it and hung up on the person. She ended up getting paid for what she used, unfortunately. And then some people have noted improvement, like students have been able to use it with the app. It's so Be My Eyes is a video call, but Bespecular is not. Good to know. Sorry. Oh, getting caught in the chats. Okay, so OrCam has it's a little device you attach to a pair of glasses, and it uses AI technology to detect text, gestures, face faces, not exactly helpful with masks nowadays, colors and other objects in your space. And there's a couple different versions. There's the OrCam My Eye or the OrCam My Reader, and they both detect different levels of things. So you can do like your watch gesture, and it ends up looking at your wrist, and it tells you the time audibly. It has multiple language functions. It can do face recognition, which is great. Color detection, depending on the kind that you get. It can even do written text. It's not super great with it, but it can. So it's improving with its OCR technology over time. And so they have since then come out with the OrCam Read, which is this little handy um, handheld device that you hold over your text to capture the page and to read. So it's basically just an OCR strictly in this case, and so it'll read out the text for you when you hold it over your page. So it's just a little handheld device, having it attached to glasses. And then the OrCam My Eye is an AI device that you wear. So you can see she's wearing it here with the camera pointed out. And it tells you when you last saw this person. It has business contacts, colleagues. It's meant for more social interaction. It sends a smartphone notification to the app to tell you who this person is, where you saw them last, if it's part of your business contacts, if you sort of establish them as that, and so that you know who you're engaging with from a networking perspective. And the battery life is 8 hours. The Seeing AI phone application does the same types of things that the OrCam does. It uses that AI technology with your smartphone's camera application to be able to do a lot of the same sort of things by reading text, reading barcodes, acknowledging faces. However, again, this is a major battery suck. Your battery can die really fast with this application, unfortunately. I like it. I show it to a lot of patients. It's really helpful, but that part is a bummer. So again, I mentioned it does all of the same things that the OrCam can do, but sometimes there's a little added features, and they keep updating it every few months with maybe a little improved reading, text reading, or they have a little bit improved reading of currency or color scans, or being able to do face recognition and that type of thing. So it's little by little. I mean, that one is a little easier to update because it's just the application on the phone. So those are some of the adaptive technologies that have come out with augmented reality and AI technology. Another thing that's come out sort of more recently is the VES Falcon autofocus bioptic from Ocutech. So most people know about bioptics, the little telescope that's attached to a pair of glasses that allows individuals to see distance targets better, or to be able to even drive. And so it's usually intended for patients who have moderate vision loss, so 2300 or better. Usually that 2070 to 2300 range is pretty beneficial. The autofocus is the pair of glasses, and it attaches to this battery pack. And it's a wide field Keplerian optical telescope system that changes focus depending on the image presentation in front of it. So like if your phone can autofocus nowadays, it's like that. It autofocuses on something closer or further away, depending on what you're putting in front of the telescope. And it has the 3, 4, and 5.5x. You can, of course, put prescriptions in there in the carrier lens in the bottom, which is great. And they have some additional filters that you can attach. It has a 8-hour battery life. You can set it for optical infinity when you want to drive. so that you don't accidentally focus on your dashboard and then you're missing something in the distance. So that's helpful. I have a patient that's actually had a really good success with this. He is a bioptic driver, but also a student. And so he uses it a lot for presentations. So he looks in the distance, copies down his notes, and he like looks up close and then copies down. So he has really good range with that, which is wonderful to see. Yes, this device would be very helpful in a classroom setting. The question. You can also do these devices. You can do like a distance telescope with a reading cap as well, or you can use a regular bioptic with the spin wheel on the top. I unfortunately do not have these devices with me. I'm at home, unfortunately, today. I wish I had been at the clinic today, but I am not. In order to use these devices for driving purposes, you have to go through a bioptic driving program. Thank you, William. That's a good question. The bioptic driver training program is provided by multiple resources throughout the state of Indiana. Each state has their own sort of recommendations or requirements based upon the state law, but bioptic driving is an option for those people. Some newer magnifiers that are in the pipeline that have come out recently, they're fairly similar, so I kind of put them next to each other. Is you've got the Visualux XL FHD, which is a much larger, if you remember the Ruby or a Pebble or Candy or any of those smaller electronic magnifiers, this one's quite a bit larger. It has a much larger area to work with. And then there's the Optilec Compact 10 HD Speech, which has OCR technology, which is great. It's also a touch screen. So these are, in comparison to your large extra large CCTVs, these are a little bit smaller, which is great to see, so that they're a little bit more portable for patients to be able to use these devices for near tasks, and you can hook them up to cameras for distance as well. So that's great. Before I move on to the next section, are there any additional questions to address before I move on to convergence insufficiency?
There were two that I saw. One was asking about implanted technology.
Yeah, that's a really good question. I thought about including it. There are a couple different implant technologies that have come out. What they do is when they replace the lens of the eye during cataract surgery, they can do an implantable telescope. However, the success rate is a little questionable. It says that, I think someone had mentioned they had it done. Where was that?
Yeah, they said they had a veteran that had
Yes.
the monocular implanted.
Mm-hmm. So if a patient has difficulty with depth perception or doing monocular, like one eye doing one distance and another eye doing another, that's definitely not recommended. So there has been, I've heard of cases of it. We don't have anyone that does it for us personally yet. I haven't worked with any surgeons personally that have do it. However, I think if a patient can get over the monocular aspect of it constantly, I think it's a really good potential option. So there have been a couple sort of intraocular lens implants with these type of monocular telescopes. The power magnification, unfortunately, isn't super high, but because it's so close to the focal point, that causes a significant higher amount. So using a 3 times magnifier at that distance actually means a lot more because of the focal length that you're working at. Okay. And then there's apparently a bioptic presentation occurring later. That's great. You should attend if you are interested. Bioptic driving is great. I see those patients all the time. Okay. Any other questions before I move on to, oh, retinal implants. That's a really great question as well. So there are some studies into retinal implants. If you remember vaguely the Argus, not so great. People didn't like it. They actually disliked the Argus because of the pixelation that it provided. As for full like transplants, that's not really a thing yet. That has worked successfully. Other implants that they've done sort of have that wireless connection like to a stimulus, but again, they're all really pixelated. They don't provide as adequate a vision that patients want. And so you end up having this sort of distortion or the success rate isn't great, unfortunately, at this time. Yes. Okay. Ooh, apparently Freedom Scientific will be releasing a new handheld electronic portable magnifier later this year called the Juno. It will have OCR capabilities. Thank you, Jim. That's great to know. OCR is becoming a lot more popular with these electronic magnifiers, which I'm really excited to see because it expands the use of those devices. Okay, any additional questions before I move on to convergence insufficiency? If not, you can email me later and I will try to get back to you as quickly as I can. Okay. I'm going to move on to oh, the price of the Falcon. That's a really good question. I want to say 3,000, but I will have to double check that because I don't know exactly off the top of my head. Okay. Convergence insufficiency is a condition you actually come across pretty regularly with visually impaired, non-visually impaired individuals. It's pretty much across the board. A lot of people have a difficult time with near tasks, especially right now because we're all staring at computers 24/7 now, and we don't take mental breaks. We don't take vision breaks. We just stare at our computers all day, every day, and our focusing systems and our convergence systems are becoming exhausted. So convergence insufficiency, I'm going to go over. It's also called CI, the definition, some symptoms, the symptom survey to help individuals who do, like anyone can do this survey, can run the test, and then sort of other testing that we use to help distinguish what it is, what causes it, how to differentiate it from other conditions, and then our treatment options. So CI is a condition that a patient has a difficult time maintaining proper alignment at near targets. So when you look up close, so from out here to looking up here, right? So I'm looking much closer, 3 things end up happening. Convergence means your eyes move in together so that you have to look at a target. So I go from far away and my eyes move in closer. The pupillary response is that your pupils constrict to be able to focus on that near target. And then accommodation, which is our focusing system, has to kick into gear. This, unfortunately, accommodation worsens with age. So when you get to be about 40, you start noticing, oh, my arms aren't long enough anymore, or your focusing system just isn't as up to snuff. You can't read up close really easily like you used to when you're fully corrected, mind you. All of these things can be affected by changes to your brain, such as a traumatic brain injury, a stroke, a concussion. However, they can also be affected by other things. So convergence insufficiency or convergence changes can be, they can occur spontaneously anytime. You can have them whenever. They can be affected by your glasses prescription. Accommodation, as I had mentioned before, can worsen as we age until you're about 65, until your accommodation is pretty much kaput at that point. And that's why we need reading glasses to see up close. This can be affected by our glasses prescription, and then our pupillary response can be affected by changes to our brain or other vascular conditions that can occur so that they don't work as well. So I'm not really going to talk about the pupillary constriction aspect of it as much as I am the other two. So common symptoms of CI are rubbing your eyes, blurry vision up close, tearing at near, headaches, especially when you're reading, eye strain with near tasks, double vision up close, or if you notice a child having some disinterest in reading or in near tasks, they just only want to play outside, they never want to read. Of course, you have to sort of distinguish that out, like from other children who like to play outside versus reading. But it can be a sign of those issues. So what does this even mean? What does convergence mean? So convergence is your ability for your eye muscles to pull your eyes in closer together. And you have sort of three different postures that are possible. You can have meeting a target. So that's your normal convergence. So my finger is here and my eyes are perfectly aligned to look at my finger. Or you can have convergence insufficiency or not converging enough, basically meaning I'm supposed to be focusing at my finger and getting my eye muscles to move here, but I'm actually focusing or getting my eye muscles to only move to a distance out here. So it's not getting all the way into my finger. So they're not moving in far enough. Or there's an excess where they turn in too much. So I'm looking at the target I'm supposed to be focusing on as my finger, but I'm actually focusing somewhere much closer here. So I'm not actually looking where I should be at my finger. I'm actually looking at something in space here. So my eyes are turning in too much. This often happens when our eye muscles either aren't working strong enough inwards or they're working too much. There's not enough compensatory outward movement. Um, and so we can have this um, excess or insufficiency depending upon how our eye muscles are working together. And this can also change and vary throughout the day, especially if we're tired. So if we're staring at near targets all day, every day, and not giving our eyes a break, we can end up with having these symptoms sort of by the end of the day. I know for myself, I have convergence insufficiency. I can compensate pretty effectively. However, when I am exhausted, I start to see double because I can't bring my eyes in close enough to focus on that target, and I end up seeing double vision. So these are sort of the most common issues that you get. There's a whole slew of them. They're sort of broken down into convergence, divergence, and accommodative issues. So convergence, again, is your ability to move inward. So if it's insufficient, it's not coming in enough to look at a near target. So you end up looking further out than you should. Excess of convergence is moving your eyes inward too much. So you're looking actually at a point in space closer than what the actual target is indicating. Divergence is your ability to move your eyes outward to look at sort of distance targets. So divergence insufficiency is your inability to move your eyes outward to focus at that distance target. And divergence excess is moving your eyes out too far when looking at a distance target. So you actually have to parse out things like divergence excess from convergence insufficiency because they both mean your eyes are moving outward, but it's different because of where you're looking, if you're looking up close versus far away. And then you have accommodative issues, and that's dependent upon how our lens changes shape over time to be able to focus from far to up close. And as we age, I mentioned that focusing system becomes worse over time. And so by the age of 40 or around there, we start having more focusing problems up close. Unfortunately, even more so now we have those issues because we're working from home, looking at our computers all the time. Kids have devices that they're constantly staring at, not letting their focusing systems have a break. And so we're constantly using our accommodative system to help us do these up close tasks. And so you have insufficiency, where there's the inability to make that image clear up close, regardless if you're using one eye or two eyes. Excess, where you're focusing too far close, so too close compared to the target. Infacility, meaning that you have a hard time switching from a distance target to a near target. Your eye muscles, that part is separate. It's literally just, can I keep this clear? Can I keep that clear? Can I keep this clear? Can I keep that clear? And being able to switch back and forth between the two. Accommodative spasm is where your focusing system basically gets stuck at one focal distance. So if I'm looking here constantly and then I look far away, my focusing system is still stuck for here. So it's not that it takes a really long time to switch, it's that it literally can get stuck. And so instances for myself, especially during grad school, when I was doing a lot of near tasks for very long periods of time, I would be looking up close constantly, doing studying or reading, and I would get accommodative spasm because I wasn't letting my focusing system relax. So I'd do way too much near work, and then I'd look up to look at the TV or out the window, and everything would be super blurry for at least 5 minutes or something like that. And I couldn't focus far away because my accommodative system was spasming and getting stuck at that near focus. So how do we test for convergence insufficiency? We do this with the Convergence Insufficiency Symptom Survey. So it's this lovely blue test. You basically ask each of these questions. There are 14 of them, and you basically go from 0 to 4 on, do your eyes feel tired with near work? Do you feel eyes feel uncomfortable? Do you get headaches? Do you feel sleepy or fatigued? Do you lose concentration? Do you have trouble remembering what you just read? Do you sometimes get double vision when you read? Do words swim around or jump or float? Do you feel like you read really slowly? Do your eyes hurt? Do they feel sore? Is there a pulling sensation? Do you get words blurring or coming in and out of focus? Do you lose your place when you're reading? And so you kind of 0 is never and 4 is always. And you rank them. You can do this for children or for adults. So for children under the age of 21, 16 or higher is highly suggestive of convergence insufficiency. And then for adults, these numbers are a little bit more laxed so you get 21. And that's because as we age, our focusing system gets much worse. And so it's not just about how our eye muscles work, but how our eye muscles, sorry, it's not so much about how our eye muscles work as it is our focusing system not working, called presbyopia, where we have to have reading glasses, that accommodative issue. And so anyone can run this test. You ask the patient these different questions and you categorize them 0 to 4. And then depending on the answer, you can sort of make an appropriate referral from there. It might just be something as easy as wearing glasses correction, but I'll go into how to test for that otherwise. And so additional testing that you can do for this is your distance acuity or near acuity. So that's determining the highest resolution that a patient can get far away or up close. And so if your distance vision is better than your near vision, it could be a convergence issue, but you also have to consider a patient's age in that realm. So if they're not wearing their full reading prescription, then they of course could have accommodation issues instead. And so you want to make sure that they're wearing their full correction for each specific distance. If they're at distance, wear their distance RX, at near, their near RX. There are other conditions, of course, that you kind of need to rule out, like I had mentioned before, accommodative insufficiency, presbyopia, and divergence excess. But these are good indications that, hey, there might be something not perfect in their vision system. So this is the whole slew of tests that we can do. I'm just going to go over a couple of them. So these are things that we do in our exams, especially for binocular vision exams, to go over all of these types of tests to give us information about how our eye muscles are working together. So another test is the near point of convergence. Anyone can do this one. You have a patient focus on a small near target, a letter, point of your pen, some type of more like discrete smaller target, wearing their habitual near glasses. So if they wear reading glasses or if they just wear distance glasses because they're younger, whatever the case may be. You bring the target in and you tell the patient to focus on that target and let them know when it doubles, when it becomes fuzzy, or blurs, um, or if you notice the patient's eye start to move out. So I'm focusing, and oh, my eye just kicked out. So you do this multiple times, you repeat it because you want to fatigue the system a little bit. If they can do it once and done, great. That doesn't tell you a whole lot. If they can't do it multiple times, that gives you an indication that their system is fatiguing really fast. And that could be an indication of convergence insufficiency. And so you bring the target in multiple times to get them to look at that near target. And then you measure the distance from their eyes to the uh, place in space where they first reported double blur, where you notice their eye physically move out. Um, Foria and vergence testing. Foria is a test to determine where your eye's natural posture is when you break fusion. So when your eyes are not perfectly fused to look at a single object, they kind of relax, um, either inwards or outwards. And so exo is outward drift when fusion is broken, and esophoria is when your eyes tend to drift inwards when fusion is broken. And so, for instance, I have what's called an exophoria. And so I'm looking at a target, I'm covering an eye, I'm covering an eye. We alternate back and forth, and it's kind of subtle, but my eyes have a tendency to drift outwards when I break fusion. So alternate covering the eyes is what's breaking the fusion between the two eyes. And I have an exophoria, meaning I have to move my eyes inwards because it's drifting out when I break fusion. And so they have a tendency to drift apart. Vergence testing is testing the the eye muscle's ability to compensate for this drift tendency. And so the higher amounts of corrective vergence that an eye can have is better to be able to cover that potential drift that your eyes do. So if you have an exophoria of this number of prism diopters, and that means how thick the prism is, it gets thicker and higher as you go up. Versus I have, 12 diopters, or the 12 is the amount that my eyes can compensate. And so I shouldn't have symptoms, right? If I have even, double the amount of the potential to correct the issue, then that will help. And so it's like, I gained 6 pounds, but I can lift 40 pounds, so I'm okay. It's your body's ability to compensate for that issue. If that vergence testing that you do can't compensate for the eye's tendency to drift in or outwards, when they break fusion, you can experience blur, discomfort, eye strain, double vision, and headaches because you're not able to compensate effectively. Okay. So how do we treat this? You can prescribe the patient's full glasses prescription. You want to make sure that they are fully corrected for their distance and near, so that you can help alleviate the eye muscles strain. Because if your focusing system isn't working correctly, oftentimes your eye muscles will try to compensate or help the situation, or vice versa. If your eye muscle system isn't working, your focusing system is trying to correct that. And so they all work together. It's called a dual interaction model, basically meaning that the accommodative system and your convergence system work together to help you see up close. And if one is kind of faltering, the other system tries to come in and kick in to help the situation. But in doing so, it can also lead to additional symptoms and problems. And so we want to make sure we try to help each system out individually so that they can work better together. You want to make sure that the full glasses prescription is provided. So that lovely one or two question that you get at the eye doctor is great. And that's how we determine that glasses prescription often. We can also do it in objective ways if you have a patient who has cognitive deficits or is a young child. So we don't necessarily have to do the 1 or 2 system. Other treatment options include vision therapy. For convergence insufficiency, especially, vision therapy is actually the best way to treat it. And that is by increasing your vergence ability. And so that's basically going to the gym for your eyes. It's working your eyes out so that they can adequately compensate for the eye's tendency to drift outwards or inwards. In this case, convergence insufficiency, when you're looking up close, they have a tendency to drift out a little. And so these therapy options are a great way to help bolster your eye muscle movement so that they can compensate effectively. And we often do these in office. Um, we can use many different types of training to help get the eyes to work together, including tranaglyph, where you use different stimuli colors to each eye. And so you wear these fun red green glasses, and you have to get the two images to fuse together. And so you get good binocular vision. And as you work on it, it can get further and further out. So you get better and better, and your eye muscles can, compensate even more and more effectively as you work on it. And this is something that you can do in office. And then you can also do at home therapy with which is called HTS, the home therapy system. And it is a computer program that does fairly similar sort of training, but at your own pace at home. Usually, what we'll do is we'll have a binocular vision therapy done in office every week or so. And then the patient will end up doing some home therapy as well in addition, so that it's not just, oh, you're going to the gym or working with your personal trainer. You work with your personal trainer once a week, and then they teach you how to do your own at home workouts so that you can get your system sort of back up to snuff. Other things that can be done that are actually quite simple and cheap is called the Brock string, and it is a good way to give you an indication if you are seeing double or not up close. And so you see this little girl, and she's looking up close at these near little beads. And as you improve your focusing system as well as your eye muscle system, you can go from looking at the green bead to the yellow bead to the blue bead to the black bead to the red bead, and you can get further and closer in as you progressively work those eye muscles. It's kind of like a push up for your eyes. So if you go from a further target, a little closer in, a further target, and then closer in. And then as you can do this one, then you can start going from the yellow to the blue bead. And so you can even get further in. And so just like with push-ups, if you do, the demand, if you do like a leg push-up, you're on your knees and you're doing the push-up. It's a less of a demand than versus when your legs are straight out in front of you doing a full push-up. And so you work up your demand, and you work up to being able to do these different types of tests, the types of training and eye muscle movements. Another way that you can help treat it is with Prism. Prism helps shift the image toward the corner, the pointed part, the apex, to help align the image. So it's shifting the world or the view so that it matches where the patient's eye sits, so that it can give you a better, clear single image. So if you remember Pink Floyd's cover with the prism, it's not about separating light. In this case, it's just about shifting the image. So if you look at the light comes in and then it's bent in one particular direction, that's exactly what it's doing. And so it's shifting the image towards that corner so that it aligns with where the patient's eye actually sits, and so that you see the image single and clear. Usually we try to do vision therapy first because Prism is a little bit more difficult with convergence insufficiency, in that patients have a tendency to adapt to Prism and need higher and higher amounts to help compensate. They kind of adapt to it, and so that's not super helpful. We want to make sure that we find what's most beneficial. Prism and you get older, does that eventually not work? Nope, you can actually, depending on your situation, Prism can be effective throughout your entire life. It honestly just depends on how your system works. Another question is, does vision therapy only help with younger patients under 40? Nope, you can do vision therapy as you at any age. So okay. You can do vision therapy, especially patients who've had like a traumatic brain injury. They can end up with convergence insufficiency or other eye muscle issues or accommodation issues, and we can often train those. And so there's a lot of really good potential with those types of treatment. Okay, great. Samples, conversions, going to share clips of this video, parents and staff as a clear explanation. Okay, great. Yes, from concussions as well. So any type of change to our brain, mild to severe, you can end up with these types of eye muscle issues as well as focusing issues. So we deal with a lot of concussion patients at our clinic, traumatic brain injury patients, and they all end up having a lot of these types of visual issues. Do you recommend a TVI to ask these questions? You can. Tommy Roche, you said, so do you recommend a TVI to ask these questions when you are doing an FMLA for student that is diagnosed with this? Yes. So if a student is doing vision therapy, they should be improving slowly over time, but making accommodations in the meantime can be very helpful. Um, and then speaking to a TVI's role when it comes to CI in those situations. Um, yes. So having a teacher help with those types of situations while they're undergoing that therapy can be very good. And so it just depends on the level at which it's occurring and how to help the student. And so having good communication with the eye care provider is really important in those situations. Making sure you have frequent breaks during near tasks is really good. Making sure that they either are using their glasses if they have a full prescription, making sure that they're doing their at-home therapies to make sure that they're um, improving on their tasks. And if vision therapy isn't working completely, that's when we start considering other options like prism therapy, or if it's called atropia or strabismus in that case, where the eye is constantly sitting in that position, it doesn't have a tendency to drift, it just actually is in that position, then you can consider a surgical option to help align the eyes. Birth to 3 kids and I request for prism to correct muscle balance problems. Do you ever recommend prisms for very young children? Yes, we do recommend prisms for very young children depending on the eye turn issue. Oftentimes when you're very, very, very young, like an infant, you're not going to have good control over your eye muscles. However, as you get older, that improves. However, if you notice a tendency for an eye muscle to drift out in your, infant to toddler age, that's not as normal. So making sure you get an eye exam sooner and letting your eye care provider know is really important. There's the Infant C program that helps individuals do eye exams on their kids from about 6 months to about 2 years. So it's a program that allows for eye exams early on, so you can figure out some of these issues sooner than later and to see if they're normal. So there are normal eye postures that happen when you're an infant versus when you're 4 or 5. And so you can catch some of those things sooner than later. And then Ron later says, how long after strabismus surgery do you see improvement? Is there a definite window for improvement? So that's a good question. Strabismus surgery oftentimes will correct the issue if it is a basic case. If there are issues, sometimes they're not fully correctable, but then after the strabismus surgery, then you can do correction with a prism at that point, and that's a little bit more feasible. So you might need to do a little additional vision therapy or prism after that surgery as well. And then, can a TBI administer the CISS? Yes, anyone can do this convergence insufficiency symptom survey. If you get higher numbers on it, that's a good indication that you could potentially, say, hey, you might have some issues with your eye muscles. Maybe go get a full eye exam to make sure that you get that checked out. So anyone can do that. Do you see as the role of the TBI when parents opt out of vision therapy due to cost? That's a good question. So yes, vision therapy can be very expensive. It's weird. Optometrists do not get coverage for vision therapy with insurance. Occupational therapists do. It's a weird insurance system. We don't really understand it ourselves. So making accommodations for those students can be very helpful by allowing frequent breaks, making sure they have their full glasses correction, maybe giving them a little additional time on those situations. So especially for near work, those can be some accommodations to consider. Yes, line guides are great. I love them. You can easily use a line guide to help so that they don't have that swimming kind of vision. Um, told not to use a line guide. Being done at vision therapy. I don't know about the vision not being able to use a line guide for vision therapy. I mean, if you're having issues in that exact moment and you need to read that statement or read that page, like a line guide can be very helpful. I'm not sure where that information is coming from. So, while you're doing vision therapy itself, maybe not using the line guide, but when you are doing other tasks, using a line guide can be effective. That answers that question. Okay. Any other questions? Awesome. You guys are great. This is my email, ehable@iu.edu, and you can also call our office, 317-274, sorry, this should be 278. That number is not right. Anyway, 278-1470. Just look up Indianapolis Eye Care Center. That's where we are. If you have additional questions, please feel free to email me. I'm always available. Thank you guys. You guys rock.
Can you type in your email in the chat so that people can actually see it, just in case they didn't catch it when.
Perfect.
Thank you. All right. Well, we thank you very much. And Emily, if you watch your email in the next couple days, you should be getting a thank you gift from us.
Oh, thank you. You guys
You're
are great.
We appreciate your time and everything and your information. It was very helpful, very interesting. So as you see in the chat, the closing code is CARE, C-A-R-E. And